Unfortunately, colorectal cancer remains a very commonly diagnosed cancer in both men and women in the United States.
The American Cancer Society estimates that there will be over 95,000 new colon cancer cases and 40,000 new rectal cancer cases in the United States during just the year 2017.
On this week's Health Talk, we'll discuss treatment for colon and rectal cancers with Dr. James McLean. He's an expert in this field.
So stay tuned, we're up next.
Hello, I'm Dr. Andrea Peterson.
And I'm Dr. Eric Mazur. Today we'll discuss a really important topic, the treatment of colon cancer. Our guest is Dr. James McLean. Dr. McLean is Chief of Colon and Rectal Surgery at Norwalk Hospital.
Welcome back to the show.
Thanks for having me.
So, Jim, you're a specialist in colon and rectal cancer. Tell us a little bit about the treatment. So maybe starting with colon cancer. And I know that it's variable too, isn't it?
It is variable. So again, just a little bit of anatomy. The colon, or the large bowel, is about 5 feet long, and the rectum is that last 6 inches just before the exit point. And the treatment of colon cancer is somewhat different than rectal cancer. There's certainly some commonalities. Before we talk about treatment, I'll talk about some of the diagnostic studies we do to stage the cancer. And by staging, I mean try to get an idea of whether it's localized, whether it's spread to other organs. So when I first see a patient who's been diagnosed with colorectal cancer, one of the things we'll do is get a CAT scan, which is an X-ray, CAT scan of the entire body, the chest, the belly, just to make sure that it's contained. And if it looks like it's contained where it has not spread to other organs, then we start talking about surgical treatment. There's been great advances in the other arms of oncology treatment, chemotherapy, radiation. The bottom line is, though, the cornerstone of curing a colon cancer is usually with an operation. So it's unusual to be cured without surgery. So,
and the great news with that is that if it is at an early stage, it can be cured with
and
surgery.
As long as it's contained to the bowel and the lymph nodes that are local to it.
The earliest stage colon cancers are absolutely curable. Cure rates are over 90%.
Which it emphasizes the need to detect these cancers at an early stage in terms of screening for our viewers as well.
We do know that the cure rates, are much higher if we sort of do a screening test and you detect this without symptoms versus waiting for symptoms to develop, and then having a workup at that point.
And maybe you could point out that symptoms from colon cancer are pretty unusual in its early stages.
Symptoms could be, yeah, absolutely. You could have no symptoms. Some of the symptoms that you may see, rectal bleeding, any kind of change in your bowel pattern, you go in less frequently, more frequently, a change in the caliber of stools, abdominal pain, unexplained weight loss. So these are all some of the things that potentially can signify a problem.
And so for your patient, perhaps they've had their colon or rectal cancer diagnosed with a colonoscopy for screening if they haven't had symptoms, and now they're coming to you, said you've done a CAT scan to look for whether it may have spread. And tell us a little bit about how that affects the treatment.
So with the treatment of colon cancer and rectal cancer at this stage are a little bit different. For colon cancers, once you've established the fact that it hasn't spread, what we'll do is do an operation, remove that segment of the bowel. Typically we can reconnect the bowel, so it's very unusual to need a colostomy, whether temporary or permanent for colon cancer. And the way I explain it to patients, we'll take out the piece of bowel, we'll send it to the pathologist who will examine it, and then they'll report back to us with the stage. In general, if the lymph nodes that we take out with the bowel have cancer in it, then we typically will recommend chemotherapy. If the tumor is just contained to the bowel, has not spread to lymph nodes, traditionally we have not recommended chemotherapy, and the majority of those patients will not need chemotherapy.
And maybe we could explain the rationale behind that a little bit, that when the cancer has spread to the lymph nodes, it means that there's a higher likelihood that there are microscopic deposits of tumor that have not been removed, and so the chemotherapy is designed to knock those out.
Exactly. So it's called, the term is adjuvant. So we're giving chemotherapy not because there's any measurable disease on a CAT scan, but just in case there's some cells, like you said, that may be sitting in another organ in the liver that just can't be picked up on that CAT scan.
And the size of the tumor and the presence or absence of lymph node involvement really helps us statistically to know what that risk is.
Absolutely.
That it's higher if those are the case.
Exactly. Now the treatment for rectal cancer is a little bit different, and that's where we start depending more on our oncology colleagues. in general, if someone has a rectal cancer, again, that first 6 inches, we'll do some additional testing to try to get an estimate of the stage. We want to sort of see how deep the tumor goes into the wall and whether lymph nodes are involved. And the two ways we do that are with either an MRI or an ultrasound. The reason we do that up front is that if we do know that we have a rectal cancer that's locally advanced, meaning, again, through the wall or in the lymph nodes, we actually prefer to shrink that tumor before we do an operation. So that's where we kind of mobilize the whole
so is that
oncology
because the
team.
operation is more difficult to do technically because it's sort of down deep in the pelvis, or is it for other reasons?
Part of it is the location in the pelvis. You know, the rectum is sort of sitting in the bony pelvis, and like you said, it's a little bit more difficult to get clearance. And also, there is a sort of a higher, if you just sort of remove it like you do colon cancers, there is a higher chance that the tumor cells can come back at some point. You know, there's lots of other organs that are very close to the rectum.
And there's no lining over the rectum the way there is over the colon, right?
There's not, certainly not in the lower part of the rectum. So if we do have someone with a rectal cancer that looks like it's maybe gone through the wall, then again, we sort of mobilize our colleagues in radiation oncology, medical oncology. What we do is discuss these patients in sort of a multidisciplinary conference, and then come up with a management strategy as a team. And again, for these advanced rectal cancers, we'll typically give them a course of chemotherapy and radiation first to shrink it. Usually that's done over about 5 weeks. And then we'll wait maybe somewhere in the 8 to 12 week range, and then we'll do an operation at that point. And we're finding the majority of these tumors do shrink. You know, probably about 20% of the time that the tumor cells have actually disappeared, believe it or not.
Wow.
From these.
Which shows
these
we're really
treatments.
doing something.
Absolutely. And then we'll sort of
That's a
embark
good
on our surgery.
prognostic sign too, isn't it? If the tumor
That's an excellent prognostic sign if you've had that kind of response to the treatment.
I think what you're describing too is we're seeing that highlighted in lots of fields of medicine, that it really takes a team, a multidisciplinary approach to best treat many medical conditions, doesn't it?
Absolutely. We don't all sort of exist in silos. I mean, and the patients, it's been proven that patients do have better outcomes when they're treated by a team, a cancer team. Not even just cancer, I think in a lot of medical specialties, but certainly in this area, when we sort of, again, discuss it with other specialties and talk to the pathologist and discuss it with the radiologist and go over the films and sort of come up with a plan as a group, and then follow the patient as a group and do the surveillance and all that, it certainly has better outcomes.
Now, people are always so concerned about having a colostomy and having how often is that necessary as part of the surgery?
It's unusual. I mean, it happens at times, but in general, unless the tumor really is so low down, where it's actually involving the anal sphincter complex, if it's most of the time we can actually do a reconnection. So it's unusual, but there are times where you do need a permanent colostomy, but it's fairly infrequent. And some of the techniques that we have now, we really can, as the technology gets better, we can do these operations and really salvage the anal sphincters more than we used to.
And how about the survival rates in patients who've had these procedures?
It really depends on the stage. I mean, again, if someone has a stage 1 colorectal cancer, your survival rates are really up over 90%. So again, these are curable cancers. Which goes back to the message of the earlier they're picked up, the more curable they are.
Yeah, so if they haven't involved lymph nodes, if they haven't gone through the wall, their survival rates are going to be in the 70s, 80s, or maybe better than that.
Yeah, I mean, again, if a stage, yeah, exactly. I mean, I think if it's perhaps through the wall, or certainly if it's in the lymph nodes, then you're probably more in the order of 60 to 70%, that kind of thing.
Which is remarkable in and of itself to think that this has already spread to a lymph node, and yet modern therapy gives you about a 70% cure rate.
Absolutely.
Yeah.
I think it's worth highlighting for our viewers too that we have tended in the past maybe to think of colon and rectal cancers as being cancers of older age, but we're seeing now some increasing rates of these cancers in younger people, aren't we?
We are. I mean, several reports have come out recently that do point to the fact that the colon and rectal cancer is increasing in patients under the age of 50. There was a report that came out within the last year that looked at patients born in 1990 versus 1950, and we're actually finding that if you're born in 1990, your risk of colon cancer is double to that if you're born in 1950, and your risk of rectal cancer is 4 times as high as someone who was born in 1950. So there's something going on that we're trying to figure out.
Strange.
And it's more than just the fact that these patients aren't being screened. I mean, they haven't been screened in the past and they're not being screened now. So
Right.
There's some factor that's increasing, which is the important message here is that younger patients should not ignore symptoms, and if there's any of these symptoms that we kind of talked about in terms of colorectal cancer, they should be brought up to their physicians.
Right. So again, bleeding, change in bowel habits, change in caliber, diameter of stool, weight loss,
abdominal
pain, get those checked out.
Yep.
Right. You don't want to wait till you have a cancer that's encircling the whole bowel and is obstructing the bowel and giving you an acute abdomen as well as a more difficult surgery.
Absolutely. Absolutely.
People used to present with that as their primary manifestation of colon cancer, and I know that that's a bad prognostic sign.
Exactly. Yeah, when you present it obstructed, certainly that's a higher risk factor. And even some of that in the past, some of those patients that maybe have an earlier stage but presenting with a bowel obstruction, we may be more apt to sort of treat them as a higher stage, i.e., give them chemotherapy and whatnot. The other thing I want to bring up is that the surgeries that we're doing for colorectal cancer are much less invasive than they used to be. Traditionally we used to do open surgery where you make a sort of a large, big incision, and then do what we have to do and whatnot. We're doing a lot of minimally invasive surgery now for colorectal cancer. So laparoscopy has been around for quite some time. People know it as keyhole surgery, where you make a little incision, put a camera in, and make little slits to put instruments in. We do know that those patients have a shorter recovery time, lower infection rate, lower hernia rate, less pain. So there's big advantages.
Does it make it easier for the rectal surgery? I just remember from the old days people complaining literally about how difficult it was to get down into the pelvis and see well. And if you're able to do that robotically, doesn't it take that problem away?
It is. So laparoscopy is what we just talked about. Rectal cancers are somewhat challenging to do laparoscopically. People do it, and people are very good at it. Robotic surgery is something, it's a newer technology that's been around that we do a lot of. Similar to laparoscopic surgery, although rather than having myself and perhaps a couple assistants holding instruments and the camera, the Da Vinci robot is a cart that you attach all the instruments to, including the camera. Then I, as the surgeon, sit off to the side and take control of the instruments, take control of the camera. I look at a magnified screen that's 3-dimensional. The instruments sort of mimic my wrist movements as opposed to being, for instance, an instrument at the end of a long stick, that kind of thing. So my feeling is that this certainly increases the number of patients that we can offer minimally invasive surgery to.
And unfortunately, we're out of time, so I have to cut you off there. But yeah, the technology of the surgery itself has really become dramatically different.
That's so important for patients.
To the patient's benefit. It's out of time for now. We'd like to thank our guest, Dr. James McLean, for joining us on Health Talk today.
For viewers, please do send us your questions and comments at healthtalk@wchn.org. We'd love to hear from you.
Thanks for watching.